Good morning, everyone. Thank you for joining us today. I will ask you to please rename yourself with your practice location and your name in the Manage Participants box. Okay, that's all I had, and I'll turn it over to you, Kathleen.
Hi, good morning, everyone. I just had a couple of reminders before we get started. Just some feedback from last week. Just a reminder to everyone, think about the language that we are using when discussing diabetes, obesity, or any chronic disease, really, that we want to try to recognize, patients as individuals and not defined by their disease that they might have. So for example, instead of using the term diabetic, say person with diabetes, instead of saying, an obese patient, you could say a person with obesity. So with that, I will present the disclosures here. These were also emailed to you separately. Great, and so I will just let Liz Beverly and Goutham Rao continue from here. Our topic today is health literacy and numeracy and its impact on type 2 diabetes.
Thank you, Kathleen. So I'm Liz Beverly, and I'm from Ohio University Heritage College of Osteopathic Medicine. I'm going to tackle the first part of health literacy and then pass it on to Dr. Rao. So these are our objectives. We're going to describe the scope and impact of lower health literacy upon the self-management of type 2 diabetes. We're going to define patient numeracy and then describe the impact of lower patient numeracy in the self-management of type 2 diabetes. So the broad definition of health literacy, and this is by healthypeople.gov, and then also looking at health literacy, there was a book that came out in 2004 with a very well-known definition. It's the degree to which people have the capacity to obtain, process, and understand basic health information and services to make appropriate health decisions. And you could expect that in diabetes, with all the different self-care behaviors that an individual is expected to follow, that health literacy is incredibly important in terms of obtaining and processing and understanding different types of health information. So there was a very recent, as in 2019, that came from PLOS ONE, there was a systematic review and meta-analysis. And as we know, that's the best source of information if we're going to make any type of evidence-based medicine decision. There was one that came out looking at the prevalence of health literacy across the globe. And then what they did is they assessed all of the different studies on health literacy as it relates to type 2 diabetes. And they came up with a global prevalence of 34.3%. So you see it's slightly above a third of the global population having low health literacy. And then of course, since the majority of the studies, approximately half of the studies came out of the United States, they also assessed the US prevalence. And you can see that the US prevalence was 28.9%. So approaching nearly a third. I do want to make a point here, and this point is that a lot of the research shows on health literacy, and this is not necessarily in the type 2 literature, this is the general literature on health literacy, that education mediates the relationship between health literacy and health outcomes. And if you think about that, the education, if someone achieves a higher level of education, that allows someone to have better access to healthcare. It allows for better communication skills with a provider. And if you have more communication with a provider and better access, you'll understand more terminology, which will improve your health literacy. So specifically, in terms of the impact that health literacy has on type 2 diabetes, there were two other systematic reviews and meta-analyses that came out very recently looking at the impact that it has. And this is their findings. So lower health literacy is associated with less diabetes knowledge. That's a very consistent finding. It's also associated with higher A1C levels. Now, what's interesting is that there are very mixed findings with self-care. So what is consistent in terms of the self-care is that it's associated with decreased exercise or physical activity and decreased foot care. So what's mixed is the relationship between taking medication, between following a healthy diet, and some of the other self-care behaviors. So that's why I have an asterisk there. And I also have noted that the relationship here observed with self-care is only significant in studies that are using self-report measures. So keep that in mind. It's the people who are self-reporting what types of self-care behaviors they are doing. Lower health literacy is also associated with difficulty communicating and understanding medical terms when speaking with a provider, and less desire to participate in shared decision-making with a provider. And so what is this impact? Again, well, looking at some of these systematic and meta-analyses, They also identified that we still have certain gaps in knowledge when talking about type 2 diabetes and lower health literacy. These are the gaps that we still don't have answers to. We don't really know the relationship between health literacy and self-care. And then relatedly, we don't know the relationship between health literacy and self-efficacy. And we know, based off of hundreds of studies, that self-efficacy is related to self-care, particularly with type 2 diabetes as well as with type 1. We don't know if there is a gender difference with health literacy and type 2 diabetes. And also in talking about, well, what can we do in terms of interventions to improve health literacy? We don't have the interventions to determine the effectiveness in terms of experimental design, meaning we don't have the randomized control trial evidence to see what works for health literacy. We don't have the cost effectiveness interventions, and we also don't understand the environment. So the reason I'm talking about the environment is the data that I cited about looking at the global prevalence. Most of that research was coming from assessments in the community and not assessments in the hospital situation or in private practice. So there are differences depending on where you do the study. If you do a health literacy study in a hospital setting or in a practice setting, you tend to actually have higher health literacy than if you do it in a community setting. So there are types of health literacy, and this is where we're going to then transition to Dr. Rao's presentation. In terms of health literacy, think about it. I'm talking to you right now. This is a form of oral literacy. I'm speaking to you and you're comprehending, I hope. There's print literacy, there's reading and writing, and then you have numeracy. And you can expect that with diabetes, particularly if somebody's on insulin and counting carbohydrates, their understanding and their ability to apply numbers is particularly important. So now I'm going to pass the baton to Dr. Rao.
Thank you, Dr. Beverly, for that excellent overview. So you're not going to learn everything about health literacy or numeracy in the few minutes that we have. And I think my goal is just to energize you about the issue. About 5 or 6 years ago, I was at a conference in the UK, and one of the speakers did an experiment. And his premise was that we, as the upper middle class, the well-educated members of society, which all of you are, tend to overestimate the resources that our patients have. So his experiment was this. Can you tell me what the 90th percentile of income in the United Kingdom is? Now, I'm from the United Kingdom, I don't know, but I guessed £100,000 per year, about $130,000. And most of the people made similar guesses. One person said $1 million, which is ridiculous, but it was kind of all over the map. The actual answer is 40,000. 40,000. We were stunned. And then he pointed out, yes, people like you tend to overestimate the resources that people have. And that, incidentally, applies very greatly to numeracy. We overestimate our patients' ability to use numbers. So broadly speaking, the ability to understand and work with numbers is numeracy. It's the degree to which individuals have the capacity to access, process, interpret, communicate, act on numerical, quantitative, biostatistical, which is really more advanced, and probabilistic health information needed to make effective health decisions. If you don't look after your feet, you have a 30% chance of an amputation. Not well understood by our patients at all. So I was the one who coined the term physician numeracy. This is more than 10 years ago. And just as an aside, the story was when I started in practice in rural Ontario many years ago, there was an editorial in International Pediatrics that describes it. Because I'd been out of numeracy for so long, and I was working with a very inexperienced nurse, she was drawing up a racemic epinephrine for a child with croup. It was like a 20-month-old girl. And I divided my head, it was all in vials back then, and I made some divisions in my head. But by the time she had no idea, she was just starting out as a nurse. She was about to give the child 100 times the dose that was appropriate. But I caught myself and realized that we have a problem. So it's not just patients, it's also us. We are so out of touch with our facility to use numbers that we need to re-engage with it at some point. So let's talk about our patients. So numeracy is a broad term. It involves counting, obviously, calculations, times, and dates, which sometimes we wonder why our patients are not on time. And I'll explain why that might be in a moment. Fractions, decimals, probability, of course, higher order mathematics, contextual skills, logic, is very, very difficult for many of our patients to understand, especially people who are economically challenged. So here's the scope of the problem. This is kind of a classic statement. It's been around in the numeracy literature for a very, very long time. And that is, if you have a patient who takes the bus, most of my patients do take the bus to come to the clinic, and they know what time the bus arrives, and they know how long, they know what time they've arrived, for example, at the bus stop, and they know exactly how long the bus takes to get to our offices. They cannot figure out how long the total journey would be, for example. And that's 32% of adults in our society across the US population, 110 million Americans. So that says all economic classes, races, ethnicities. So you can imagine that among our patients who are disproportionately at risk for type 2 diabetes, the Medicaid population, low numeracy is extremely prevalent. The other problem is people are very good at hiding it. Most people can read, of course. As Liz did an excellent job of the overview of low health literacy, that's a big problem. But boy, can they hide their facility with numbers, okay? So you don't say things like, I want you to reduce your insulin dosage by 20%. If you lost 5% of your body weight, you might have improved diabetes control, okay? I want you to split the dose of 300 milligrams into four times a day so that you'll be taking 75 a day. They might get that, they may not get it, but chances are they won't understand it. And as Liz said, low health literacy, of course, is associated with a number of adverse health-related behaviors and outcomes. Numeracy, even more so, the association is even stronger. So what are we gonna do about it? Well, boy, have we tried. So this goes back to my work in Chicago. I had this grant I submitted a long time ago with some experts in numeracy from the University of Chicago. Our idea was to train adults, actually with many with diabetes, to improve their numeracy skills to see if it improved their control. And we never got funded. And one of the reasons was, and we found out later on, is it's very, very difficult as an adult to learn to improve your numeracy skills. Try trying to take up the violin when you're 45 or 50 years old. It's not going to be easy to do. A lot of our set patterns in how we process numbers are established at a very, very young age. And also, it's extremely embarrassing for patients. It's like, being unable to read. It's one thing to have poor health literacy and say, I really don't understand what my options are for this cancer treatment, or I don't understand what the complications of diabetes are. But it's much more embarrassing to say, I'm not sure if I can answer this problem, which is if your blood sugar is in this range, how many insulin units did you take? Only 85% of the general population got it. So they were able to figure out that 295 lies between the interval of 281 and 330, and that they should take 3 units. That's 15% of the general population. I guarantee you it's much higher among populations that are at risk. So training doesn't work. And the other thing that one of my mentors in this field told me about is we assume a lot of people have basic knowledge of numeracy, graphs, directions, etc. There is a large proportion of the adult population that cannot distinguish between clockwise and counterclockwise. Turn your GLP-1 agonist pen clockwise to get to 1.8 milligrams. Maybe not going to happen. So you have to be careful. So the number one thing we need to do is to be aware of low numeracy. Now, the other thing we can do is to assess it when we suspect that this is playing a significant role. So there's a number of tools that are available. There's a diabetes numeracy scale. It takes about 10 minutes to fill out. So if you find that you have a motivated patient who seems to be concerned, who seems to be struggling with something, this may be one of the reasons to do so. How do you overcome this is a bigger question. Well, trying to train people and trying to explain things to a patient in terms that you understand, he goes, is not going to get you very far, and it's extremely time consuming. If somebody doesn't understand proportions or fractions or ratios or intervals, or even how to multiply, subtract, and add simple numbers, there's no way you as a provider can train them to do that in the context of your visit. And it's really not your job to do it. There's two things that we believe are best approaches to the problem is secure the help of a friend or a relative, number one. The other thing is, as you put together a treatment plan, you know, forget about numeracy, okay? You take 2 pills in the morning and 1 pill at night. That's very different than saying, take 300 milligrams in the morning, 150 at night. So it has to be very, very straightforward. The third approach, and you'll see this written up in reports from the RAND Corporation and Health Affairs, et cetera, is to use pictures to convey risk. You have a 5% chance of having a stroke if your atrial fibrillation is not treated with an anticoagulant per year. That means nothing to most of our patients. When you show them a pictogram that shows 100 little, you know, bodies and they're all white and then one is red, 5 of them are red. You can say, well, if 100 people have atrial fibrillation, this is how many people will have a stroke per year, okay? That is better easier to understand. And of course, it's not always possible. Thank you very much. I think we'll stop. We've got a couple of minutes for questions for Liz and myself.
Thank you, Liz and Goutham. That was really great. And I think this is really critical for us to understand when we're taking care of people with diabetes and to recognize. You know, I've thought that, and before I go on, may I please remind everyone that we're open for questions. You can use that chat feature or you can unmute your microphone. And while we wait for questions, I'll just throw out, you know, a question there. What do you do about the person who says, yeah, I understand, I know what I'm doing? How do you handle that situation?
I can start, Kathleen. Thank you for the question. That's a very common response, especially with respect to numeracy. Okay, yeah, I know how to take this medication, or I know, you know, hemoglobin A1C, I know what it's supposed to be. I know it's spinning out of control. Again, it's very, very sensitive. It's embarrassing. And especially in the context of type 2 diabetes and weight and other cardiovascular risks such as smoking, there's so many sensitive issues to discuss with a patient. So the only thing I think that is helpful is a teach-back method. Okay, I'm glad you understand, but I want to make sure that you and I have the same sort of mutual understanding. Let me give you a situation. It's Wednesday, and remember, you know, maybe their insulin dose changes on certain days, or I don't know what's going on. It's Wednesday. Can you tell me how much of a long-acting insulin you would take at night on that particular day? And if you are comfortable with the answer, of course, that's a good way to assess it as well.
Well, I was just going to say that I really appreciated this talk because I think sometimes I'm a fairly new practitioner, but I would get caught up in maybe I was giving information overload instead of taking this into consideration. So even sometimes with teach back, they may be able to teach back, but it's do they really understand it? So I really appreciated this talk.
Thank you, Alicia. I think that, you know, I think maybe Liz might agree with me. It's better to assume low health literacy and low health numeracy for everybody, even people that seem quite sophisticated and well-educated. You can't go wrong by saying, okay, do a little bit of teach back, even for those people.
Great. Okay. Are there any standardized ways to assess numeracy other than asking the patient directly, or key questions you might suggest asking to get the sense of it upfront rather than waiting for a concern about the treatment plan to develop?
There are a few standardized tools, but there's no, you know, there were some tools about, you know, one or two quick questions about numeracy. How many, you know, I don't remember them offhand, but your next appointment is on October 15th. Can you tell me how many days that is from now? It seems like a really straightforward question, but it's a quick way to assess their skills. Now, a lot of people will get it, but if they take a whole minute to give you the answer, then you might have low health numeracy. I don't recommend those things. Again, you know, there's ways to assess numeracy. They are very sensitive. That can be a very tough thing to put an adult, you know, a 65-year-old patient with diabetes on the spot and saying, can you tell me how many days there are between now and October 15th? There are tools to assess numeracy, as I said, specifically. But I think that really the best way is, because numeracy is such a broad category, it involves, you know, percentages, numbers, adding, subtracting, graphs, etc. Just ask them what their understanding is about some aspect of it, and make sure that you're on the same page.
I'll add to that really quickly. I believe this comes out of Vanderbilt. So this is the short version of the diabetes numeracy test. It's very commonly used in research, but it can be used in practice. So it's just going through, is having an individual look at labels and answering questions based off of this. It's free to use. You can just Google, it's by Vanderbilt. And it's just going through questions. Again, a lot of this is based off of labels, nutrition labels. And then you have to calculate things based off of blood glucose levels. So these are the different questions, and I will send this to Shannon. She can send it out to everybody. I think it's a very nice tool. And again, looking at a syringe, I don't believe they've updated this, but I think this is a really nice tool to use. There are lots of other ones. There is a long version too, but who wants to do a long version? So these things are very, very helpful. And then there are some very functional health literacy, like things like the TOFLA, where you actually look at a pill bottle and answer questions off of that. And what I'll say is these things are great, but it's really easy to make a mistake on them. So I've used these for research, and even me going through them, and I would consider myself hopefully highly educated, I can easily make a mistake just because some of the questions are written in such a way to almost make you make a mistake if you don't read the fine print. So, yeah.
So Christy O'Day had a comment I think that was helpful. Scroll up again. When I'm working with residents, I ask them to do patient-centered rounding where they present in the room. I think that I've seen that this really helps patients understand better over time how to present their concerns to their provider. Interesting. I would consider this part of health literacy. It's learning how to communicate their concerns to their provider. I think that's a fantastic idea. I actually have had that same experience, and actually the patient will correct you, and as you go through some aspects of it, no, I'm no longer on that medication. And that tells you that you have a very engaged patient as well. And of course, they'll ask follow-up questions. So I think it's a wonderful idea, especially for the inpatient setting. The other thing, I teach in the outpatient setting mostly, is when you go back to see a patient with a student or a resident, there's nothing wrong with reviewing your understanding of what the patient might know right in front of them. It goes, okay, so you've decided you're going to put Mr. Smith on a higher dose of insulin, and he's going to be taking this at night, et cetera, and seeing if the patient has an improved understanding. There's nothing wrong with reinforcement, which seems to be one of the keys for numeracy, is going over it over and over again and not getting frustrated yourself, which unfortunately happens quite often. There's another message.
This is Adam. I just have one additional comment. This discussion has been really, really great. And so I'll start it off with a short anecdote. A number of years ago, we were conducting a study of a piece of health information technology, and we included in the evaluation a health numeracy screening tool, one of the ones that has been mentioned. We had a number of participants participate in the study, and at one of the organizations where we were deploying the survey, one of our participants was the vice president of finance for this really large organization. And one of my research assistants came up to me immediately after he finished the evaluation and said, can you believe the vice president of finance just totally failed the numeracy screener, the health numeracy screener? And I said, wow, that is a little bit shocking. But there's also something that's been described in the literature called domain effects, which is, and so I was editor for a paper that's now published in Medical Decision Making, where they compared people's numeracy abilities using simple math operations, so converting a fraction to a percent or a decimal to a percent, just really basic numeracy operations. They did the same thing, but they crafted it in the domain of a financial problem. So converting dollars and cents as sort of decimals to percent or fractions. And then they did the same thing. So the exact same numbers, the exact same operations, they did the same thing in the health domain. And what they found is that in multiple samples, participants were less likely to be able to complete the numeracy operations when they were presented in the health domain than in the financial or the plain math problem. And so one of the things that stands out from that work is that for a person who might actually have a higher level of education, they still may have poor health numeracy. And there's something specific about health, about manipulating numbers in health, that makes it more difficult for many individuals. And so I think that's just another warrant for what Goutham was saying about, this sort of blanket assumption, like, make an assumption that folks might struggle with these numeracy operations and really use teach-back and all the other great strategies.
Thank you, Adam. There's a couple other comments, and I'm happy to read them, but I don't think I can answer them all. So from Sherry, if someone does not understand sliding scale, do you just do fixed dose before meals? I've done that with a lot of patients. I can tell you, Sherry, I don't use a sliding scale for my patients. Some of them have come to me. I've only been here for 4 years, and they're on a sliding scale. But for the most part, I think it's very difficult for them to understand. But I think Kathleen might have some insight into that as well.
I think that first of all, most patients cannot count carbs very well. And so any kind of tools that you can use, to help them, for example, bolus calculators, we now have smart insulin pens. If they're getting there, but maybe, need some extra help. But for the majority of people, especially with type 2 diabetes, there have been, several studies that have demonstrated that a fixed meal dose works just as well as carb counting. So I think if they have a general understanding of, what is a carb, that's a really great starting place. And another, if you've got somebody who can incorporate a little bit more sophisticated knowledge, you can give them a big meal, small meal concept. So, so Dr. Joyce will be joining us to introduce herself and present our case.
The other part, I think, is that it takes so long to get them engaged in this. If you're able to, that sometimes it just, it's better to just talk to them on the phone, which of course is not nearly as effective. So I think a lot of people have had that experience lately.
Mm-hmm. Yeah, I wonder, it seems like, can we safely predict that if someone has difficulty with numeracy, that they might also have difficulty with technological capability?
So there's somebody actually who's in my department, Dr. Amy Schoen, who's studying that very issue. I don't know about numeracy, but the number one predictor of technological illiteracy, if you want to call it, is age, and of which one would expect. Our younger patients are much more techno savvy. They may not be numerate or health literate, but they're much more techno savvy. And I'm confronting this issue a lot with some of my oldest patients who are expected to join virtual visits, print things out. One lady asked me the other day, what is a PDF? My daughter says I need a PDF, and she had never heard of it before. So we've got a huge, there's going to be a huge gap, I think, in care just for this reason right now.
Yeah. Someone is asking about Ribelsis, whether it's covered by Medicaid. It's not covered. Mary replied back that it is not covered. Trulicity and Victoza, which is dulaglutide and liraglutide. but you can complete a prior authorization. Thank you for that, Mary Lee.
Tina, I just had one question. Did you have trouble getting coverage for Repatha? Or because I guess
no.
Okay. All right.
No, actually, Repatha's become much easier. I started using it when it first came out, and we had to do a lot of prior auths. With his history of having the bypass surgery with such significant blockage, it went through.
Thank you.
But I chose the Rebellus because that has it decreases the risk of MIs for patients. That was one of the reasons why I went with that one. He's already doing one injection, wasn't crazy about doing a second injection, so that's why I didn't do Ozempic.
Great. Someone asked about marijuana use. Repatha indicated because LDL not a goal. Okay. Any other questions about this patient? Oh, here we go. How does this patient perceive his quality of life? Dr. Joyce, could you address that?
Yes, he feels that things are good. He's becoming more physically active. He's finishing some cardiac rehab, which was delayed due to COVID, but he feels good. Can you guys hear me?
Yes, I can hear you.
Okay. Okay.
What about, does he have a treatment goal?
As far as numerically?
Well, his most recent A1C is 6.0. So I'm assuming that's okay for him. Since he's
Yes. It's for him, for his age group, probably if I can keep him under 6.5, I'm happy. I think the Ribulus is just probably a stronger medication that he needs, but again, I'm using it secondary for the cardio protection.
Well, one of the things that's really interesting in this case in particular is that, you know, his A1C, we might call that tightly controlled. But, you know, personally, it doesn't, you know, bother me a lot because we know he's not going to be at significant risk for hypoglycemia. So as long as he's tolerating the medication, can afford it, he will get hopefully some benefit from a cardiovascular standpoint. It can be used in patients with certain degrees of chronic kidney disease, at least to sometimes even as low as CKD4. Had you thought about an SGLT2 inhibitor at all? Just throwing that out there for discussion.
Yeah, for him, prior to realizing he had coronary artery disease, we were discussing using one of those. At that point, he was a little more anxious to do anything that was injectable. I'm sorry, SGLT1, 2, yeah.
It's oral.
So, or am I thinking the wrong class?
Yeah, that's GLP-1s. Yeah.
One. Gotcha. He was on Jardiance before he had diagnosed CAD. I had him on Jardiance.
He has CKD as well, right?
Yes, 3.
Yeah, so there's, I think, Kathleen can correct me, I think there's a very recent study that just came out that shows greatly decreased mortality and morbidity among patients with CKD who are on an SGLT2. That was called it.
Yeah, so the Credence study, there are a number of cardiovascular outcomes trials that for which renal outcomes were the secondary endpoint as well. So it might be something to consider with the eGFR of 69. You know, I don't think that you need it. Obviously, you don't need it for A1C reductions. The one thing to be mindful of in terms of choosing between a GLP-1 and SGLT2 inhibitors, if they do have moderate renal impairment and really more down to an eGFR of 45, below that you won't get glucose lowering, but you could get renal and cardiac protection over and above an ACE inhibitor, for example. I don't know that that's something that you have to do, just something to consider. Any other thoughts from anyone else on an SGLT2 inhibitor in this patient versus using a GLP-1?
Kathleen, Jane had a question about what I was wondering about as well for Tina. Does he have children or someone else who can participate in his care with him?
I believe 3. 1 is out of state, 2 are local, and 1 is more active in helping, yes. Is the question if they can help them access the like the education, the diabetic education?
Hi, Dr. Joyce. Yes, I was wondering if there's anyone who could help him sit in on his dietary education, or anyone that helps him with his meal preparation. I imagine being a primary caregiver to his wife, he probably needs convenience meals more than anything, perhaps why he went for some canned meals. So if there's someone who could be helpful to him, that may enhance his results.
I can check into that. I know that both of the daughters that live locally work full-time.
Right. Yeah, and I know that some of the feedback that I get from my patients who have Meals on Wheels is that they don't feel that it's very carb friendly and or diabetes friendly. Does anybody have experience with Meals on Wheels?
I would be really curious to see if this, variation in control and these health beliefs are somehow related to his health literacy as well. If Polish is his maternal tongue, the instruments are certainly available in Polish as well.
Thank you.
Yeah, one last comment. With winter approaching, could he participate in silver sneakers, get himself out of the house, as long as as long as he feels safe? I suppose along those same lines, when safe, there adult daycare is available for his wife during the day on